Well, let's finish our pediatric respiratory system tonight. Okay. So far we have done two clusters. So we have done with chronic cough cluster, and we have also done with acute shortness of breath. But we left with asthma, so we'll start with asthma today, and then we'll move forward, and hopefully we should be able to finish the cluster today. So asthma, most of the time it comes like the second question, as you see here. So father comes to your GP with his boy diagnosed as asthma 3 days before, recently discharged from hospital, but now is stable. Your task is to take a short history from the father, explain to the father how to use puffer with a spacer, and give long-term management plan. So that's typical case, but there are cases where you might need to take a history to diagnose asthma. So like it can come as a 3.5-year-old, runny nose and cold for 2 weeks, but mother concerned that the child is catching up cold a lot these days. So sometimes it can be just like child is having on and off coughing a lot. And when you follow the chronic cough cluster, you will be able to diagnose asthma just using all the questionnaires that we have done. So we will do this case because chronic cough cluster we have already done. So this is a child who has been hospitalized definitely because of severe asthma attack. And now the child is stable, but the father is here to know more about asthma. So your approach in this case should be like this. So hi, this is Dr. or you can say hi John, I am Dr. Arsham. I'm one of the GP who will be taking care of your child today. I understand from the note that your child was hospitalized because of asthma attack. Is that right? Yes, doctor. Well, I'm very sorry to know that. How is he doing now? Is he okay? Yes, doctor, he's fine now. Well, I'm going to ask you a little bit more questions about what exactly happened, and definitely we will discuss more about asthma and further management plan. So John, tell me a little bit more about the day when you needed to take him to the hospital. What was the symptom? So the parent will give you some symptoms, but you will need to know in detail about the attack. So you need to know that is it the first time this happened? And what are the symptoms she had at that time? How short of breath was he? Because we want to know that if the child was using his neck muscles, and also was he turning blue? Was he alert, agitated, or confused? So mental status. Was he able to talk, or he was so short of breath that he was not able to talk? So this will give us a fairly good idea about the symptoms. So what were the symptoms? How short of breath was he? Was he using the neck muscle? Was he active, alert, or drowsy? Was he turning blue? So just ask a few questions. How long she stayed in the hospital? What was the treatment that was given at hospital? And what medications were given after discharge? So it is very important to know that what treatment was given after discharge. That means most of the time, if it is the first time diagnosed asthma, hospital might just start the child with a reliever, which is Ventolin or salbutamol. So they can start with a short-acting beta agonist, which is salbutamol or Ventolin, and that might be the only thing that they have done. And they ask their parents to go back to the GP for a consideration of a preventer. So we want to know what medications were given. So first you asked about the attack, then find out the pattern of asthma. So apart from this episode, has she ever got shortness of breath, chest tightness, coughing, or any musical sound from his chest? Now, if it is first time, then there will be no pattern because this is the first time. But if this is happening for a while, then you will ask these questions. How frequent she is getting these attacks? How many days in a week and how many nights in a week? So this gives us an idea that if the asthma is well controlled or not. So, but if it is for the first time, then we will not ask any of these questions. Okay, so no questions if it is first time. But if it is not the first time, then we will be asking how many days a week she's getting the symptom, how many nights in a week. How does she feel in between the attacks? And does she get symptoms before any exercise or activity? So there are asthma which only happens during exercise. So that's exercise induced asthma. So you have asked about the attack. Now you have asked about the pattern of asthma symptom. Then ask trigger. So what makes it worse? Does it get worse in exposure to pollen, dust, pets, carpets, or any cold air? Does she get frequent viral illness? Anyone smoke at home? So these are all trigger factors. Pollen, dust, pets, carpet. And quickly ask about the birth history. So how was the birth? Was there any complications? Is he immunologically up to date? How is his growth and development? Any other past medical history, especially any history of eczema, allergy, hay fever? Any family history of asthma, eczema, allergy, or hay fever? Okay, so that's usually your questionnaires. It will be very short history because you will need to have more time to discuss the management. Okay. So you've got the attack and then the pattern and then the triggers. So that's pretty much all the history that you need to take. Okay. What's happening with the screen, Dr. Kaur? I think rejoin, then it might be okay, or your Zoom might require a bit of update.
Okay, okay, I will rejoin.
Now, coming to the management. So once you have taken the history, you are going to the management part, which mainly take your all the time. So this is the key point that we are going to cover. So explain what is asthma, avoid trigger factor, take the medications properly, check the inhaler technique, asthma action plan, which is very important, and just refer them to an asthma educator and a chest specialist if needed. So that's the key points in your management. So first, explain what is asthma. So say, John, thank you so much for all the information. Now, you know that your child has got asthma. So asthma is a condition characterized by inflammation and narrowing of the airway in response to certain triggers or allergens in the environment, such as dust, pollen, smoke, pets, or carpets. It usually presents with a cough, shortness of breath, chest tightness, and a wheezing sound from the chest. The exact cause why it occurs is not known, but sometimes it can run in the families, and it can be related to other conditions such as eczema, hay fever, or allergies. It usually gets worse with certain triggers. So discuss all the trigger factors. So it is very important to avoid these triggers to prevent further attack. So you explained asthma, and now you advised to avoid the triggers, then medication. Also, it is very important to take the medications regularly, especially the puffers with appropriate technique. So now I'm going to show you how to use the puffer appropriately. Are you with me so far? Yes, doctor. So you will now discuss the patient how to use puffer appropriately. So let's have a look. So I'll show you a video from National Asthma Guideline, how to use the puffer, and then we will come back. So first remove the cap, and then the mouthpiece of the puffer will go into the spacer. So this is the spacer. So you've got the inhaler and this is the spacer. So first remove the cap. So you can see that this is the positioning that it will be. So this is the inhaler, and the inhaler will go into the spacer, and the mouthpiece of the spacer will go inside the child's mouth. Okay. So remove the cap, and then you put it inside the spacer, and then put the mouthpiece in between the teeth and also close the lips around it so that there is no gap for the air to come in or out. Then you breathe out gently into the spacer. Okay. So first you put the mouthpiece in between the teeth, close the lips around it, and then breathe out gently. You haven't pressed the puffer yet. Keep the spacer horizontal like this and sit straight. And then you press the puffer. See? While you're pressing the puffer, you take a deep breath in slowly and hold the breath for 5 seconds. Now, two things can be done. In here, you can see that you press the puffer and then you take a deep breath in and then hold the breath for 5 seconds, or you can also breathe in and out for 4 times. Any of this will do. And then you breathe out. If this is understandable for everyone, how to use the puffer? Yes? Do any of you want me to repeat it, or you're okay? Okay. Let's have a look again. So this is the puffer and that's the spacer. Remove the cap and then put it inside the spacer, and then put the mouthpiece inside in between the tooth, and then you breathe out gently. And then you press, take a deep breath in, hold the breath for 5 seconds, and then breathe out. Okay? So that's how you can do it. So that's what we have written in here, that how to use the puffer. So you'll just need to explain this, that first of all, remove the cap from the puffer. And we say that when you use the puffer, you can shake the puffer also. So shake the puffer well, and then insert the puffer into the spacer. And then we will ask that, like, place the mouthpiece of the spacer in between the teeth, close the lips around the spacer so that no air can come in or out. Then ask the child to sit upright and breathe out gently. Press the puffer, and then you take a deep breath in, and either you can take the deep breath in and hold for 5 seconds, or you can just breathe in and out for 4 times. Whatever you do, it's fine. Okay? So that's what you are going to explain to the parent. So this is how we need to use the puffer. Everyone clear about it? Yeah, so you can shake the puffer before opening the cap also. Doesn't matter, it's okay. All right, now the next. Once you have explained that, you will say that it's not a bad idea to talk about the reliever and preventer before you start the asthma action plan. So you have said that you also please take the medications appropriately. So I'm going to talk to you in detail that how to use the puffer appropriately. Then you explain how to use the puffer appropriately, and then Now, this is the part where you need to understand asthma. Without having a good knowledge on asthma, you can't just like memorize a note. So there are times when we need to use preventer with reliever, and there are times when we can just use reliever. So that's also important to know. So we are going into Asthma Australia so that you understand it. So this is the guideline from asthma handbook in Australia. So we say that based on the severity of flare-up, if we are going to add preventer or not, that will depend on how frequently the child is getting the symptom. So you can see in here, mild flare-up and the child having symptoms every 6 monthly, there is no indication of any preventer. Even child is having it every 4 to 6 weeks, still we might not need to go for preventer. So especially for mild flare-up. But if symptoms occurring at least once a week, even with a mild flare-up, preventer is indicated. Moderate flare-up is the one that is important for exam. So if it requires emergency department care or needing an oral steroid, that becomes a moderate flare-up. In moderate to severe flare-up, in every scenario, they will need a preventer. So our patient needed to be admitted in the hospital. So definitely, this child will require a preventer, right? Even if it is for the first time. So that's what I want you to understand, that when to add a preventer and when to just keep on taking the reliever. Okay. And sometimes the question asks that discuss if the asthma is well controlled or not, or discuss the stability of asthma with the parent. So we only say asthma is well controlled if daytime symptoms is less than 2 in a week, no limitation of activities, and no symptoms at night. And asthma is poorly controlled if the daytime symptoms more than 2 per a week, and also if there is any of this, like any symptoms during nighttime, any limitation of activities, and needing the reliever more than 2 days per week. Now, I know it is quite complex and it is quite difficult for you to grab all this information. This one is not super important for pediatric case. This one is mainly important for adult asthma, which we will discuss later on. So for now, don't focus on this, but just remember, good control means daytime symptoms less than 2 and no nighttime symptoms. And poor control means more than 2 daytime symptoms and more than like any kind of nighttime symptom. So we will talk to the parent at the moment that for your child, we will need to use both reliever and a preventer. So reliever is the medication which your child can take when she's having breathing difficulty or an acute attack. And reliever is something which you don't need to give her every day. It's just as needed. And the preventer is a medication which prevents the airway inflammation, and it also prevents further flare-up of asthma. Now, this is a medication which she needs to take every day. So you'll need to add this part during the discussion, and then you'll say, now let me discuss about the asthma action plan. Especially to, like, you should know what to do when she is well and when she is unwell. So she is well means that your child is not having any nighttime symptom and very occasionally having daytime symptoms, and her usual activities are not getting interrupted because of asthma. That means she is well. And in that case, just continue the reliever or the blue puffer. So salbutamol or Ventolin is the blue puffer in Australia. So you can just say continue the blue puffer, 2 puffs as needed. And you can use it every 4 hourly. So when the child is well, Now, this is where it will become a bit complex. The note that we have added in here, it's for a child who is not requiring preventer. Okay? But depending on how the scenario came up, we now know that this child will not only need a reliever, she will also require a preventer. Are you guys understanding this part, that why she will require a preventer? Yep, great. So now that we know that she will require a preventer, Dr. Emmanuel, why not? What's the confusion?
Doctor, beg your pardon on why the patient will need both. Yeah, I beg your pardon.
Okay, no worries. That's fine. I just wanted to know what's the confusion. The confusion, I understand that if you can see over here about the severity of the flare-up, the patient that came into the question, the child needed to be hospitalized for asthma attack. So we know that if a child requires emergency department care, that's moderate to severe flare-up. And for moderate to severe flare, preventer is indicated in any kind of situation. Okay? So that's the reason why this child will require preventer, not just a reliever, because she was having a severe attack. Making sense? Yeah? Great. So for this reason, in here, the action plan will be changed. So I will update this, but just remember that this child, even if she is well, she will take the blue puffer as required, but she will need to take a preventer. So she will also take, it depends on you what you want to do. So take 1 puff of orange puffer. So orange puffer is the Flixotide. And Flixotide Junior is normally what we give to children in Australia for asthma. So Flixotide is fluticasone propionate. Okay? So you'll need to say to the parent that the child will take the blue puffer, 2 puff as required, but she will need to take the preventer, which is the orange puffer known as Flixotide Junior, 1 puff once a day. Okay? Now you will always increase the dose based on the child symptom control. So you can start with 1 puff once a day, 1 puff twice a day. So it's up to you. How do you feel about it? So you can start with 1 puff once a day, 50 microgram, and then gradually you can increase the dose. Okay? If child having both morning and nighttime symptom, you can just make it 1 puff twice a day. So it depends on your clinical experience. But for now, you can just keep it like 1 puff once a day, orange puffer every day. When not well, it means that child is having a flare-up. So if the child start to have nighttime symptom, having morning asthma symptom when she wake up, and asthma is interfering with the usual activities. So when child is having a flare-up, it means child will wake up with asthma symptom and will have nighttime symptom. So in that time, child will continue the blue puffer, 2 puff as needed, which the child can take every 3 to 4 hourly. And the child and also the parent need to contact the GP as soon as possible, ideally within 48 hours. Why? Because then the GP can start a short-term oral steroid. So for a asthma flare-up, when child is unwell, child will take the blue puffer as needed and also that orange puffer 1 puff once a day. So that these two parts, the child will continue. The only thing that will be added is contact the GP within 48 hours or as soon as possible for a short-term oral steroid. So when there is a flare-up, the only thing that will be added is a short-term oral steroid. Okay? What is severe asthma? So if symptoms get worse, especially if the child having increasing symptom and needing the puffer, that means needing the blue puffer within 3 hours. So with the child having a severe symptom and needing the puffer within 3 hours, that means it's a severe asthma attack. In severe asthma attack, we ask the parent to follow the 4x4x4 rule. So what is this 4x4x4 rule? It means you give 1 puff and ask the child to take 4 breaths in and out, just like usual. So the child will keep the mouthpiece of the spacer inside the tooth, right? So inside the mouth, so just think in that way. So it will be like continuous puff without removing the puffer. So just think in that way that the mouthpiece of the spacer is inside the mouth. So you give 1 puff or 1 press, and then the child take 4 breaths in and out, and then another puff, 4 breaths, another puff, 4 breaths, another puff, 4 breaths. So this is 4 puff, 4 breaths every time, right? So 1 puff, 4 breaths, 1 puff, 4 breaths, 1 puff, 4 breaths, 1 puff, 4 breaths. So this is a cycle. And then we ask the parent to wait for 4 minutes. Now, if with this burst flow of puffer, the child's symptom is still not better, then you will need to call 000 for ambulance. And while you wait for the ambulance, you will continue this 4x4x4 rule. Okay? This is understandable for everyone, that what to do when there is a flare-up and what to do when it is a severe asthma attack. And what is the blue puffer? Yes, that is the salbutamol. And for all moderate and severe cases, we give oral steroid. Most of the time, yes, we do. This is clear for everyone, that what to do for like when the symptoms having a flare up and when the symptoms is getting worse. Any questions with this 4x4x4 rule? Yes, so for severe asthma, the 4x4x4 puff is given with the reliever. That means with the salbutamol. Okay, so that's the 4x4x4 for severe attack. And then the last one is danger sign. Danger sign means the child having so short of breath that the child can't speak and getting no relief from the puffer. In that case, call the ambulance immediately, say that this is an asthma emergency, and start the 4x4 until ambulance arrives. So this is the asthma action plan you will need to explain to the parent, and then you will say that I understand, John, that this might be quite tricky and quite exhaustive for you to even remember all of this, but don't worry, I will write everything in a written handout so that you can again have a look. If there is any confusion, then we can always refer you to the specialist for a medication review about this puffer. But I will also send you to an asthma educator for them to go through everything. And please don't get scared. Asthma is not an uncommon condition. And it doesn't mean that there is any restriction of your child's day-to-day life. All we are doing is to make sure that your child can have a normal life like every other kid. But we need to be careful about that she doesn't get this kind of asthma attack again. And the only way to do it is to make sure that you avoid these potential triggers that we talk about. Make sure she have annual flu injection. Make sure that she's taking the puffer appropriately as prescribed. And with that, most of the time we can prevent any further asthma attack. I'll give you reading materials about everything that I have discussed. Do you have any questions? Okay, so that will be the finishing of this. Now you can understand that there is a lot of discussion in here, right? That's why it is very hard to finish in time. So you'll need to make it in your own way, how much you can say. It's not necessary for you to say everything in here, but you need to make it up so that you can finish in the time. Okay. Any question about the asthma management, guys? So if this child was having just like a mild flare-up and the symptoms are not quite frequent, then only thing the child would require is the blue puffer. But because the child was in emergency and needed to be stayed in hospital, it was a moderate to severe attack. So for such case, you will need to add both the reliever and the preventer. What about the first case of cold and runny nose? It's just simple case. So you'll need to just find out about you will follow the chronic cough cluster. So you'll ask the runny nose questions, cough questions, and at some point you will find out in the history that the child is getting this cough every now and then. And also there is some musical sound coming from the chest. There will be family history of asthma. So some finding will be there regarding the asthma. Okay. Moving on to the next topic. Now, guys, I still didn't get any kind of, like, I'm still thinking you guys having problem with asthma. Are you with the same page? Have you understood what is 4x4 puffs? Have you understood everything? Because if you don't understand it, you will get it confused in the exam. Severe asthma doesn't come in exam. So severe COPD, severe asthma, those doesn't come in the exam. And yes, Dr. Sherry, the physical examination will be same like chronic cough. Okay, so seems like you guys don't want to ask questions about asthma and you understand it well. So we move on. So next one is allergic rhinitis and recurrent viral infection. So now we are moving on to runny nose cluster or nasal discharge cluster. Before that, Dr. Gabra, so mild asthma only puffer, but moderate use both. So for mild asthma, yes, only thing that we need to give is the blue puffer, which is the reliever or Ventolin or salbutamol. And if it is moderate to severe, then we use reliever as needed and preventer daily. And it's as long as they will have the symptom. So asthma is a lifelong thing. So these puffers will be lifelong. But sometimes we see that the child gets, once they grow old, they don't get enough of the symptoms. So if at any time it becomes like child not needing the blue puffer at all for months and months, then we can give a try to stop this medication and see how they go. Okay? Next, So 3-year-old child has come to your GP clinic with the complaint of continuous nasal discharge for the last 12 months. The child is otherwise very well, no other abnormal physical finding. So this is a case about continuous nasal discharge for the last 12 months. But it's unusual to have a continuous nasal discharge for a year, right? So once you ask the question, you will find out it's not continuous. It might be like on and off, but it's so frequent that parents think that it is continuous. So what are the differential diagnoses of chronic nasal discharge? Is there any cases where we stop the preventer? No, doctor. So a recurrent viral infection is one of the DD of chronic nasal discharge. Then allergic rhinitis, rhinosinusitis, foreign body, nasal polyp, sometimes could be related to enlarged adenoid, or even sometimes it could be indication of cystic fibrosis. So the DD of chronic nasal discharge are recurrent viral infection of childhood, which is the commonest cause. And then the other is allergic rhinitis. Others are not too important, but you can definitely rule this out, like rhinosinusitis, foreign body, polyp, adenoid, or cystic fibrosis. So you'll start with the history. Same history as we normally do, introduce, reassurance, ask an open-ended question, and then your history will be, can you please tell me a little bit more about this discharge? So you need to know since when this is going on. Is it a continuous or on and off? If on and off, then how many episodes in the last 12 months? Is it from one side or both sides of the nose? If it is only from one side of the nose, we think that it could be related to foreign body. Then ask about what is the color of the discharge? Is it watery, runny, or thick in consistency? So CCVO. Is it foul smelling? Have you noticed any blood in it? Do you think there is anything that makes it better or worse? Have you tried any medication or seen any doctor for it? So that will be your history of presenting complaint for the nasal discharge. Then you can ask associated fever, cough, shortness of breath, or noisy breathing. So this associated symptom is for every respiratory question, right? So fever, cough, shortness of breath, noisy breathing. Then you ask about differentials. So first, allergic rhinitis. So any watery eyes, any running, any sneezing, or any sore throat. So allergic rhinitis, the main feature is itchy eyes and itchy nose. So does he keep rubbing his eyes and nose? So that will be the very important question to know about allergic rhinitis. Sometimes allergic rhinitis can have association with like ear infection, so ASOM, and also if it is associated with ASOM, they can have hearing or speech difficulty. So that's why we're asking in here, any ear pain or ear discharge, any problem with hearing or speech. So very commonly allergic rhinitis children gets a lot of ear infection, and because of ear infection, most of the time they can't hear anything that others are saying, so they don't learn speech, so they have difficulty with speech or hearing. Enlarged adenoid. So any mouth breathing or any snoring at night, and if it's yes, does he look very tired and sleepy in the morning? So children who has enlarged adenoid, they can snore at night. And because they can't sleep well at night, they feel very sleepy and irritable in the morning. For foreign body, we can ask any chance that he might have put some foreign body in his nose. So we can ask that. And then quickly ask about well baby, binds, TMAC. So for TMAC, you can ask any travel history, which is not important in here, but ask about like, does he go to childcare or school? Anyone in childcare having similar problem? Ask about any history of allergy, asthma, eczema, and any family history. Ask about pets and carpets at home, anyone smoke at home, because this can be the triggers for allergic rhinitis. And any other past medical history, any family history of any chest condition called cystic fibrosis. Okay, so that's your questionnaires for chronic nasal discharge. So coming back, so presenting complaint will be like this. So you will ask all the nasal discharge questionnaires, and then you will ask the associated symptoms, and then you ask main differential diagnosis in here is allergic rhinitis, enlarged adenoid, foreign body. The other DD, like recurrent viral infection, nothing much to ask in here. So you will find out all the symptoms with your questionnaires. So recurrent viral infection, they will have all the symptoms such as like cough, sneezing, watery eyes, runny nose. So the symptoms you have already asked. Same with allergic rhinitis. For rhinosinusitis, so sinusitis can cause a headache and facial pain. So if the child is old enough, you can definitely ask the question that, does he complain headache or does he complain pain on the, like a facial pain or heaviness? Okay, that can be asked. Foreign body, you have asked. Nasal polyp, there is nothing you can ask. Enlarged adenoid, you asked. And cystic fibrosis, you are asking. And you can also ask that, does he get a lot of chest infection? And any family history of a lung condition called cystic fibrosis. So that's your DD, and you're asking all the questions anyway. Physical exam. Physical examination in here, it's more or less same. So you'll start with the general appearance. Is the child active, irritable, drowsy? Ask about any adenoid phases, because enlarged adenoid is one of your differential, and any mouth breathing. Same for adenoid. Pickled vital sign growth chart, and your main focus will be ENT. So first, ear. Any discharge from the ear. So you'll be looking for any discharge, any tympanic membrane changes such as redness or inflammation. On the nose, first on inspection, you look for any nasal crease. Children who has continuous nasal discharge for years, they develop a kind of a fold on the top of their nose, which is called nasal crease. So any nasal crease, and then you look inside the nasal cavity, and you look if the nasal mucosa looks pale and congested. If it's looking boogy in appearance, you look for polyp, foreign body, ulcer, and any hypertrophy of the nasal turbinate. So especially children who suffer from allergic rhinitis, they can have like a nasal mucosa pale and congested, boogy and hypertrophied, inferior turbinate of the nose. So now, this is a confusion for a lot of students. The case that comes under nasal discharge is one recurrent viral infection of childhood, and another is allergic rhinitis. So there is no easy way to differentiate between these two, but the important finding is itchy eyes and itchy nose. Children who has just a recurrent viral infection, they don't get these itchy eyes and itchy nose that much. Okay? Allergic rhinitis, most of the time the child will have the issue with, like, they will have itchy nose, continuous runny nasal discharge. Okay? And especially those will have association with exposure to dust, pollen, then change of weather, cold air, smoking. So there will be some trigger of having these symptoms. If you get this finding in the history, then diagnose the child as allergic rhinitis. Otherwise, the diagnosis will be recurrent childhood infection. Okay? Because even with recurrent nasal discharge, anyone's nose can become pale and congested, boogy, and hypertrophy of the turbinate. So this doesn't differentiate between these two. Is the symptom, family history, the other history will make the diagnosis. Okay? And then look at the throat for any bad odor from the mouth, which you can find in tonsillitis patient. Any throat congestion, any exudates on the tonsil, and any tonsillar or adenoid hypertrophy. And then quickly you will be doing the respiratory system, cardiovascular system, and everything. Okay? So that's your examination for this case. So how will you explain this? So let's say that this is allergic rhinitis case. So you'll say most likely from history and physical exam, your child is having a condition called allergic rhinitis. This is a condition in which the inner lining of the nose gets inflamed and swollen in response to some allergic particle in the environment, such as dust, pollen, etc. The usual symptoms are watery nasal discharge, stuffy nose, sneezing, and itchy nose. This can be associated with family or personal history of eczema, allergy, or hay fever, like in your child case. But it could be due to other causes as well. So give some differential after that. Then explain that please don't get scared. It is not a serious condition, and good thing is that we can prevent it by avoiding the allergic substances that he might be allergic. Regarding further management, first we can give a trial with a normal saline drops to see that if we can drain all this discharge, getting better or not. If it is causing itchiness or affecting his sleep, we can also give some antihistamine. Now, even with normal saline drops, if the symptoms are not improving, then we can start him on steroid nasal spray. So steroid nasal spray is the main treatment for allergic rhinitis. And sometimes you might need to give it for even 4 to 6 months. It depends on the child's symptoms. If the child getting allergic rhinitis during the whole winter time, then even you might need to just ask them to continue it for 6 months. Okay, so it depends. So you will say that definitely they can try with a normal saline drops and some antihistamine. If it's getting better, then it's fine. But if it's not getting better, then a nasal steroid spray, usually one spray each nose before the bed, will do the job. Okay, and also we are going to refer your child to an allergic specialist to find out any specific allergens. Please try to avoid smoking at home, avoid close contact with pets, and avoid contact with sick person. And then finish with 4 hours. Okay. Any question about allergic rhinitis? At what age we can keep sinusitis as our DD? Sinusitis is not very common in like pediatric patients, so it's not very commonly we diagnose sinusitis, but ideally, like I would say that even above 5 to 10, so 5 to 10 we can still consider sinusitis, especially if they're complaining of headache. Okay, but like most of the time it is usually the adolescent teenage, they usually get sinusitis. But as a DD, we can still keep it for even 5-year-old. So this was the allergic rhinitis management. So main management is start with normal saline drops, flush the nose, antihistamine, and if not, then nasal steroid spray. You have to talk about the trigger factors. So pets and carpets. So if it is a bit of large case, then you'll need to talk about like sending the child to the allergic specialist. Advise if there is anyone smoking at home, that has to be reduced, and the parents, if they're smoking, they have to go out. It should not be done in presence of the child, especially not at home. If there is a stuffy toy, like there are lots of stuffy toys at home, those toys can also have allergens, so limit the contact with them. If there is like very fluffy puppies at home, okay, so if there is pets which has like allergen in their hair, that can be another factor. So again, that needs to be sorted out. And most of the Australian homes will have carpets. So you'll need to advise the parents that they need to vacuum the carpet very regularly. Okay, so those are very important things to discuss as part of regular maintenance, because it's not just the medication which can help. Next, recurrent infection of childhood. So same scenario, but there is no itchy eyes or itchy nose. There is no family history of allergic problem. So in that case, you will say that most likely your child is having a condition called recurrent viral infection. So he's not having any alarming symptoms. He's thriving well, growing well, and during examination, there was no other abnormality. Please don't worry, it is common to get 6 to 12 viral infection in this age group. As your child is going to the child care, most likely he is getting it from there. So I would advise you to send your child to a smaller child care group rather than the large one. Also, when he gets sick, try to keep him at home, give him adequate rest and fluid, and you can give some Panadol if he is having fever. One of the causative factors for repetitive infection in children is passive smoking. So if positive, then advise the parent not to smoke at home and also offer another appointment for counseling to stop smoking. Okay, so it's very easy to explain recurrent infection of childhood. So you might need to give some differential diagnosis, say why those are unlikely, and finish with 4R. Okay. Yes, so yes, in Australia we do skin prick test. So you will not do it. So you will send the child to the allergic specialist. They might consider doing that. Family history is, yes, family history is very common for allergic rhinitis. Even if it is not allergic rhinitis, but there will be family history of asthma, eczema. So some kind of allergic problem will be there in the family. If there is nothing on the family, the patient might have some other features like eczema or hay fever. So some kind of history will be there. Okay, so now we are going to take a 10-minute break, and after that we will start with anaphylaxis. Any questions so far? And also it is very important for anyone. So when you join our sessions, you'll need to write your name so that we know who you are. Okay, so I can still see one of your name is coming as Samson. So if you can please change your name when we are in the break. Thank you.